live. On behalf of my co-chairs, Emmanuel Barbato from ALST and Thierry Lefebvre from Paris, I'm welcome you to the second day of ECC. If we just briefly wrap up what we experienced yesterday, more than 800 people registered and attended the meeting. It was, I would say, I really enjoyed it. I think my co-chairs will confirm that too. So we are looking forward to the second day with a session that will start in Singapore. Our Singapore colleagues are ready to go. We will then move to South Africa and then back to Hong Kong. And this afternoon we will have a World Interventional Forum. Basically, the so-called best cases have been selected for this final session that will take place this afternoon. On the other hand, I would like to invite you, Thierry did that in a very nice manner yesterday, that you can chat with us, that we are here to answer your questions. And I, by the way, would like to thank Thierry for taking this task over yesterday, because he's here to reply to your questions. We cannot address all the questions live, but certainly the most important ones will be discussed here in the forum. Once again, I think it's important to highlight the importance and the support of the industry. Our partners have made this event possible, and without them, we wouldn't be here. I would like you also to invite you to check the website, because you will basically see the virtual exhibition with all our partners. You can visit the virtual booths of this company on the website. And talking about the website, there is a case library with all the cases, most of the cases that have been submitted to the meeting. They are available for your review or your comments. We would also like to highlight that we have launched a discussion forum with a few hot topics that may be of interest. One of the topics is, for example, the recent EBC left main trial, or there is, for example, another trial that will be discussed. I will not go into details, the Flower MI trial. So there's stuff on the web that you can consult and that you can look into during the day. So I think we have to kick off. We have a little bit of delay, and I would like to ask Jack Tan and Paul Ong, who are the chairs in Singapore, to take over. And what I proposed, Jack, this went and Paul very well yesterday, is that basically there is a case presentation, and afterwards you as a panel discuss the case, and my co-chairs and me will interact with you on the case. And that's just really funny, because we basically have a small bird in the studio, and we thought it would come by and pass by, and it already came by. So this is the nice thing about live, virtual live. So you may see this bird again on occasion, but we'll hope will stay quiet. Okay, Jack and Paul, the floor is yours.
We're very happy that in collaboration with Endovascular Cardiac Complication 2021, Singapore get a chance to present our few cases and share our experience. So we are starting out with the Singapore HUBSPOT session. The date stamp today is the 19th June 2021, 3:15 Singapore time. And this session is jointly organized with the Singapore Cardiac Society PCI chapter. My name is Jack. I'm your chair for today, the chair for the PCI chapter Singapore Cardiac Society. With me as my co-chair is Dr. Paul Ong, well-known figure in this part of the world, my co-chair for the PCI chapter Singapore Cardiac Society. We have a list of 3 faculty, Dr. Ho Hee Hwa from Tan Tock Seng Hospital, Dr. Joshua Loh from National University Heart Center, as well as Professor Aaron Wong from the National Heart Center, Singapore. Our first plenary lecture for our Singapore HUBSPOT session, we are very privileged Professor Eeckhout to share with us his interventional cardiology and COVID-19 20, 21, and 22 personal journey and perspective. and we're eagerly awaiting his experience sharing for his opening talk. After that, we have 4 complication cases to share. We have 3 coronary sessions, starting with Dr. Hui Wen from NUHS, followed by Dr. Pinakin from WHC, Dr. Chua Jia-Min from Tan Seng Hospital, finish out with a complication structural case from Dr. Ho Kay Woon, the National Heart Center, Singapore. So without further ado, let's get started. And I'd like to invite Professor Eric Eeckhout to give us his opening lecture. Eric, please.
Okay. Well, thank you, Jack. Basically, I didn't expect...
Eric, I think you're muted.
I hear you, Eric.
I'm trying again. It seems to work. That's what I'm told. I'm getting the... We'll try to work on that. In the meantime, I'll just talk a little bit to check if it is working. So maybe while we are working on that, or do you want to start with a case first?
It's not a complication forum with a reason, right?
No.
Okay, don't worry, Eric. We'll wait for you to get unmuted first.
I'll continue to talk, so that means that at a certain moment in time you will hear me. We don't. Can you ask maybe the team in Singapore to start with the connection? You can hear me?
Now it's good. Yeah, now it's
okay.
good. Eric,
okay.
please go ahead.
Okay, because basically I was told that you should hear me, but of course, if you don't hear me, you don't hear me, definitely. So Jack and Paul and all the friends in Singapore, I'm very pleased that I'm not supposed to give lectures myself at this meeting, and I'm always a bit concerned if the people talk about your meeting. This is not my meeting. This is our meeting. By the way, I would like to welcome also Evgeny Merkolov from Russia, who just joined in. Is also one of the panelists. So this lecture is basically a 15 minutes lecture I gave at Hong Kong College, at Hong Kong Stand meeting that was also online a few months ago. And I propose to talk about a little bit how we lived the COVID period. So if you go back to January 20, and you will see what I'll talk about January 20, this is what life for all of us, I think that you all agree with me, Evgeny, Emanuele, and Thierry, that I think we enjoy clinical work. I think the core of our job is take care of patients. That's where we get most rewarded on. The second point is less fun, and I looked at Emanuele and I saw by the moment that you're working hard, Emanuele, and I think you have to endure administration. We have to endure some of our colleagues. You know what I mean. I don't have to explain this. We have to work as a team, and that's not always that easy. Definitely, we are physicians, and we are particular guys, and the ladies too. We are all particular in our job. On the other hand, we still try to enjoy life. We enjoyed life. We could travel. We could go out and party, and until January 22, life was basically not that bad for us physicians. Just to let you have a look at this is at the Olympic Museum. Lausanne is well known because it's the Olympic capital, and this was just a charity run organized a few months in summer in 2019. You see how life was, no masks, everybody was enjoying life and going for the charity run. And basically, I think that I talked about this also with my colleagues. What most of us do is enjoy this international aspect of our job, the effect to be able to travel, to move around and to see friends and to work with them. This is in Kota Kinabalu. I was just a few days before moving to your country with Huang Bong in Kota Kinabalu, and I worked in the cath lab there. We enjoyed the work. This is what is it all about, and this is the scene on the Isle of Borneo, having a breakfast in the morning. This is quality of life that we enjoyed in those days. And then moving to Singapore, and this is a picture I took of myself just before doing the PFO live case with Julie. And we see the team from Singapore over there, a picture taking. And I take the opportunity to wish you again, Prof. Ko, happy birthday, and to really highlight what a particular person you are. I can't escape to say that. And then from Singapore, I moved just for one day to Thailand and worked with these fantastic people. And once again, this is real fun. And then came 2020. That was 2020. And I would like to remind you, this small mail I got from the team from Singapore. It's very small to read, but basically, Prof. Ko told me, there is something going on in China. Don't really worry, it's a small virus. You just have to fill in this format. It will be classified. Don't worry about that. So I filled in the format. That's nothing special. So I moved back home, and that's it. And then I got some messages from friends in China. This is a lady from I know in Shanghai, and she sent me this message, and it's very small to read. But basically, what it says that terrible things are coming, and she really warned me about the pandemic that would come. And basically, when I was reading this, I say, but that's not possible. I don't believe that at all. Nobody believes that. And then came the lockdown. And when I look at that, I look at Evgeny Merkelov, because I was basically supposed to travel to Moscow for their interventional meeting. But basically, we got locked down. I was forbidden to travel basically the evening before I had to leave to Moscow, basically. And I think all the things you see over there happened to us. It was something that we never experienced in our life. And I think most of us, in Switzerland was quite different, but in many countries, and I think Belgium, France, you were in a kind of lockdown, severe lockdown. Now, what happens in the lab team? Well, we didn't go for dinner or for lunch at noon anymore. We had to reorganize our shifts, and basically we stopped meeting up. We stopped all the elective cases, and there was a drop in STEM active. You know all of that. And I think if one thing is to mention is that during the first lockdown, nobody in the cath lab team got COVID. Basically, we did very well. We were scared. I think all of us were quite scared about COVID. We didn't know basically what happened. And then came this, the webinar and the virtual meeting. And basically the first one I attended to was basically organized by Eeckhout, the company that is organizing this meeting here, set up by Max Armour on the pandemic. And you see that we had already a quite big international group of people also. Jack, you were part of it. And then life goes on. Thierry, you see yourself at the webinar organized by other colleagues. So that was the new standard. That was something that we were getting used to. So if you look at the pros of these webinars, I think you have a look inside the living room of famous people. You see also the living room of past presidents of the United States. You see, it's quite amazing to see that. Depending on the time zone, I think our colleagues from Taiwan yesterday evening, they were late in the evening, they can have a drink. You can go mute without offending. Nobody will see that. There is no official dress code, although we decided, the three of us today, and also Evgeny did that, to be in a better dress code. Up to you. And the audience looks big because the audience is virtual. We don't know how many people are looking in now. We have more than 800 people registered yesterday, but we still don't really know what the audience looks like, and we have difficulty to interfere with you who are listening and watching right now. What are the cons? Well, I think with growing age, it's difficult to hide a tired and ugly face. There is no way you can feel the body language. Body language of people, it's very difficult to understand. They often happen on Saturday today, and you should be careful the day before. You should really take care. Don't drink too much. Go to bed early. And also, depending on the time zone, you have to take care of that. And as mentioned before, it's really difficult to really feel the connection with the audience. Then came summer last year, and summer was quite nice because this is a picture that I took on holiday. So this was the new standard with the bikers with masks giving interviews. But we were able to travel, and I was able to travel personally to your country, Thierry. This very close to Switzerland. playing very nice football. As you know, people around the world, Europe is now in the ban of the Euro foot, and this country may potentially win again. We'll see. The second lockdown, then. What to say about the second lockdown? After this, fortunately, nice summer that we were able to live here in Europe, we get used to the virus. Basically, less people seem to worried about COVID. The mask, the FP2 mask were not worn, maybe different in Asia, but at least in Europe, we were a little bit behaving differently. And what happened? Healthcare workers got infected. In the cardiology department, quite a lot of people got COVID. And then we got into this kind of circle of life that we didn't really know. Basically, sleep, go up, wake up, drive to work. In France, they say métro, boulot, dodo. I think you see what I mean. Now, are we going now to the end of this 2 days life? Is something new coming? Because basically we still enjoy clinical work, maybe even more because we work, personally I work much more in the cath lab in Chieh because, well, I don't travel anymore, as is also the case for my colleagues. We have to endure administration even more because the administration is life making even more difficult with COVID. We have to even endure even more our colleagues because COVID puts tension on us. I see that in the team. It's difficult to keep the good mood that we had last year, and I think to some extent COVID is responsible. What we maybe realize today is that we enjoy the simple things in life better, something we should probably do. And what we do, at least for me, I discover Switzerland more than I did before. We travel around in your own country, and I think that, Emmanuel, I don't know if you travel around in Belgium, and Evgeny or Thierry, and you friends from Singapore, I think it's a small island, so I don't know how you manage, but you can travel around in your country too. And we enjoy streaming music and social media and television. Netflix and Spotify is all around even more. I would just like to share a case briefly because, of course, this is a complication course and we had several complications. This is one I had. So not going to details, this was a paravalvular leak that we closed. Basically, I anticipated a little bit that this would be a potential complication, and I feared blockage of the leaflet. As you can see, the tunnel of the... Voilà. My presentation got locked out. I'm almost finished, Jack and Paul. So this, while we're waiting for the slides to come back, so this was a PVL in an old man, 89 years old, father of an employee of the hospital. And as you can see, the tunnel, the alignment of the leak is not really perpendicular to the mechanical valve. And we anticipated a little bit that we could have blockage of the leaflet. And what we do in this case is really we do the wiggle maneuver. We really test the device that stays safe in place before releasing the device. So that's something very important. So thank you very much. The problem is solved. So this is before releasing the device, and of course, blockage of the leaflet after release. So we are now in the left atrium. The device is in, and of course, something has to be done. So this is snaring of the device and pulling out the device out of the tunnel of the paravalvular leak. And there I did something really not very wise. We were able to capture a part of this PVL device, but as you can see, we were not very well aligned. And I tried to pull it through the interatrial septum, which was, we pulled several devices through the interatrial septum, but here we definitely should have realized that this would not be able to be solved. So the device, as you can see, embolized in the left atrium, and we were forced to snare it again. So I don't know if you can see that because I have a hard time to see it. We were able to snare it. Basically, one part of the presentation is basically lost because, can you go back one slide, please? I can do that? Okay, sorry, didn't know. Okay, I'll advance again. So this is when we really did not realize very well what we were doing. Basically, we lose the device. You can see it over there on the right side of the screen while we were pulling it out. Here it's embolized into the left atrium. And here we will snare it. I think Thierry also had a case from your hospital many years ago where you did exactly the same. And we were able to snare it and then pull it through the intraatrial septum up to the groin. You can see that over here. So there we have it snared. And then on the second image, you will see it over here. We just pull it through the atrial septum and get it down to the groin. So that's at the level of the groin. And of course, you will never be able to get this out. So what you have to do is to go from the contralateral side, snare it, pull it out, release it, taking it all the way to the other side, putting it into the big sheet, and then taking it out. So this is one of the complications we had that I wanted to share. So to finish up, this is today. This is this morning, a picture I took. This is where all is happening in a small hotel on the lakeside, sitting together here. And this is the television studio where we are working from. This is the new standard to some extent. This is the way we are working with the team over here, with my colleagues. And this is you guys talking to us. And this was the Swiss session of yesterday. So, well, that's it. So enjoy ECC. I think hybrid meetings are here to stay. I think to some extent this may be the end or the beginning of the end of the very, very big meetings. I don't know, maybe. But anyway, I think we should learn by sharing, and I hope you will enjoy the rest of the day. And I give by that the word back to you, friends from Hong Kong, from Singapore, sorry. Bye.
Thank you very much, Eric.
Sorry,
Paul. I think, it is really quite a nice reminder of how life have changed since COVID hit us in the beginning of 2020. And a lot of what you said, I think we all echoed here in Singapore as well. I think, what a lot of us didn't expect is, not just not seeing each other for such a long time, but also facing up with the wave 1, the wave 2, and wave 3, etc., etc. And I think for some of us, the fact that we can't travel anymore, my wife keeps saying that I have midlife crisis, so we all change jobs, some of us too. I think recently we have the latest problem in Singapore, the outbreak. And I think probably best if I can grab Kay Woon, maybe you want to say a few things, because one of the hotspots actually happened in Tan Tock Seng Hospital. Maybe you can share with us how life have changed over the last month with the reemergence of these Delta variants in Singapore.
Thanks, Paul. You guys can hear me, right?
Yeah, we can see you too.
Okay, I think it was really unexpected because the outbreak happened right at the hospital, and obviously we all had to lock down the hospital for the very first time, and it was definitely something very different because all of a sudden we were on call, and then all of a sudden we had to cut back our activities. And I remember putting myself 7 times on call for May, but I didn't get called back at all, which never happened in my career before, you see. But I took it as an opportunity for me to catch up on my reading, and also to do my part to to make sure everything is safe, because we don't have to have an outbreak breaking out in the hospital. So we had to limit ourselves to traveling between the hospital and our home. That's it. And once the outbreak is over, I mean, life is back. So I think there's some adjustment to be made now. Yeah, definitely challenging times for all of us, but hopefully with the vaccination, things will get better soon.
Yeah, I believe a lot of us were put on home quarantine at that time. Is that right, Kay Woon?
Yes. I think Jia-Min was the only SR that was functioning at the time, and she's presenting today. And we had one whole department, hematology, was completely quarantined, and they had to pull someone else from a different hospital to help out with the services. So I think but fortunately we were able to control the in-hospital cluster within 2 to 3 weeks. And now we are all subjected to the routine test, the nasal swab. So something quite unpleasant.
Yeah. Jack, any comments?
Yeah, I think everyone is experiencing COVID similarly and quite dissimilar. I think the biggest thing for us in Singapore is that even though Switzerland may be small, Singapore is even smaller. So the inability to travel just make us rediscover Singapore a lot more, but there's only so much we can discover. So Eric's comment about the big meeting going away. Yes, the huge meeting might, but I believe the ECC type meeting where we do a very close-knit, very cozy type of sharing will continue to persist. And I really miss those sessions, and we're really hoping to see everyone in person again real soon. Yeah, back to you, Paul.
Yeah. So I think in the interest of time, if that's okay, maybe we can move on to the case presentations. As Jack mentioned, we have 4 cases to share, 3 coronary case and 1 structural heart. So maybe I can call on Dr. Sim Hui Wen. She's the Interventional Fellow at the National University Heart Center. Maybe Hui Wen, can you start off our first case? Over to you. So while Hui Wen is getting ready, can I just remind us that there is a voting going on? So, please pick the best of out of the 4 cases. There'll be an announcement towards the end of it. So over to you, Hui Wen.
Hi, can everyone hear me?
Yeah, we can hear you.
Thank you for having me here today. So I'm an interventional fellow from the National University Heart Center, Singapore. Today, I'm presenting a case of an unusual case of burr entrapment. So my patient is a 80-year-old man who has renal failure and he's on hemodialysis and he has CABG in 2018. He also had a leadless pacemaker inserted. So this time he was admitted for intradialytic chest pain and was diagnosed to have a non-axial elevation MI. His EF at the time was 38%. His diagnostic angiogram showed severe calcified native triple vessel disease with tight osteo-LED lesion and a tight osteo-circumflex lesion with a mid-circumflex CTO. There is also diffuse LED disease. So this is a spider view. And the right coronary angiogram showed that there was occlusion in the proximal RCA. His lima to LED was unfortunately occluded, but both his grafts to the RCA and the OM were patent. So we stopped the procedure, and after an extensive discussion with the patient, he decided to proceed with high-risk PCI with rotablation to his native left main to LED disease. And he absolutely declined surgery in any circumstances. So he returned to the cath lab 2 days later for a high-risk PCI with no surgical bailout. We started the procedure by inserting a IABP into the left femoral artery and a 7 French sheath in the right femoral artery. Next, a 7 French EBU 3.5 guide catheter was used. We used a Sion Blue ES guide wire on a fine cross micro catheter to cross the lesion and exchange out for a rota floppy guide wire. Rotablation was performed with 1.5 mm burr at 160,000 RPM for 2 runs with no issues. During the 3rd run of rotablation, there was an unusual sound with sudden deceleration of the burr. Following that, the burr was stuck in the mid-LED calcified lesion. So we're wondering what was going on. So we realized that actually the gas connector, the tubing for the gas tank to the rotablator system was actually squeezed by the automated cath lab door, which was newly renovated, and we did not notice that it would cause this problem. So this is our old door where the gas tubing actually fit nicely under the door. And this was the new cath lab door that, as you can see, when it closed, it actually squeezed the tubing in between the door and the wall. So there was a sudden loss in gas pressure that has caused deceleration of the burr. So multiple attempts of forceful burr traction were unsuccessful. We decided to use a ping pong guide catheter technique. This was achieved by passing a second guide wire beyond the entrapped burr, followed by balloon dilation of the calcified lesion proximal to it to create a crack between the vessel wall and the burr to retrieve the entrapped burr. So a second access was obtained in the right femoral artery, and we used another 6 French EBU 35 guide catheter. However, we were unable to pass any wire beyond the mid-LED lesion, even with Conquest Pro 12 Gaia 2 on Mizuki microcatheter. And repeat angiography at this point of time actually showed that there was teeny zero flow down the LED. You can see there's actually no flow down the LED. At this point of time, the patient hemodynamics was stable, but he was having some chest pain. So at this point, we decided to use a child-mother guide catheter technique. The drive shaft was cut near to the advancer, and a 7 French periscope guide extension was railed over the drive shaft. So by using a traction of the guide by using traction of the drive shaft and counter traction of the guide extension catheter, the whole system was successfully removed. Sorry, I can't play the media. So this is the part where we successfully removed the whole system by using the child-mother guide technique. Okay, so with the problem was solved, so we proceed with the procedure. We further dilated the lesion with a 2050 NC balloon, and we used a IVUS to visualize the vessel. It shows concentric calcium even up to the distal left main. So we did further modification with a 2.5 and 3.5 shockwave lithotripsy balloon. This was the result after the shockwave balloon, which was quite satisfactory. And we proceed to stent the lesion with a 2.5 38 DS overlapping with a 3.5 23 DS from the left main to the mid LED. This is the final result. Sorry, can't play again. I will show it. All right, so this is the final result. This was the IVUS pre-PCI and post-PCI. As you can see, pre-PCI, there was disease extending to the distal left vein. The MLA in the LED was 3.5. So after PCI, the MSA in the left main was 9.8. The proximal LED was 6.2. And the patient remained well. He suffered no more chest pain during his dialysis. So the management of entrapped burr, you can use the simplest method by just manual traction if that helps. You can also use the deep guide intubation. If that doesn't work, you can consider adding a second guide using the ping pong method like what we tried, or cut the rotablation drive shaft and use the child-mother catheter like how we demonstrated. Otherwise, you can try to fit a snare over the shaft and immediately pull the shaft proximal to the burr. And if all else fails, then you can consider surgery. This is a short video I got from the PCR website showing how to use the child-mother guide technique. So first, you cut the drive shaft just before the advancer. Then you pull out the plastic sheath that's covering the drive shaft. And then you load the guide extension onto the shaft. And you advance the guide extension against the pearl and pull back the whole system. So the take-home message from this is that Entrapment is a rare but life-threatening complication. In this case, we upfront use a 7 French guide, which can be helpful because if you need to use a 6 French guide extension at the end, you can only fit a 125 mm burr inside a 6 French guide extension. And always check the gas pressure, volume, and tubing before you start the procedure. And prevention is better than cure. So careful case selection, gentle packing motion, short runs, avoid deceleration, and a maximum burr to artery ratio of 0.4 to 0.6 is advisable. Thank you.
Thank you very much, Hui Wen. It's a really nice save, but just one comment is you can't actually fit the 1.25 burr in the 6 French guide extension either. Maybe can I, Aaron, you have seen every single, rotablation in Singapore and probably have, commented on a lot of the cases. Maybe can you help lead the discussion?
Sure. Thank you. Hui Wen, it was an excellent case and excellent save. I think end-stage renal failure patient is actually very common in Singapore, and somehow they live 10, 15 years, no problem. But the problem is when they presented to us, they presented with very severely calcified vessels, and the surgeon doesn't like patient with end-stage renal failure, and as an interventionist, we don't like them as well because it presents a lot of complications. Yeah. So I missed the beginning. What's the EF of these patients? The LVEF?
38%.
38%. Yeah. So this is considered a high-risk patient. I mean, to be honest, all rotablation, I consider myself as high-risk procedures because all the cases that I've seen for the complications, most of them actually related to rotablation because of the no reflow, perforation, like your case, per entrapment. So I'm just wondering for my cases with calcified lesion, I always try to pre-dilate first. Maybe we're lucky that the lesion can be dilated with the NC balloon or even OPN or cutting balloon, so that we will avoid going through these high-risk procedures, safe using the rotablation. So I'm just wondering whether would you have considered any, in this case, you consider a primary rotablation, would you have considered to pre-dilate with a high-pressure balloon in this case?
No.
I think that is one of the consideration. The initial intention from the primary operator was to proceed with the initially. So, but I think in calcified lesion, there's a possibility to use a high-pressure balloon, maybe a low-profile one, a small balloon, to try and see whether we can using rotablation, because as you said, there's a lot of complication that's associated with rotablation strategy.
Okay, so yeah, I mean, for me, I always try to use NC balloon. If the NC balloon high pressure really cannot open, then I'm no choice. We have to take out the rotablator. And the second thing is the your gas. For the rotablation, we usually sort of is in a room, isolated in a room. It's not, there's no tubing connect to from another place. So this really have a potential problem. Somebody could have stepped on it or kick on it, and then the air may just came off. And I think this is quite dangerous actually. For us, we just have an isolated oxygen tank, pressure gas. They just connect straight to the rotablator, rather than connect it to another place to get the pressure from. I think so. That's one thing that that's like you said, prevention is better than cure. If you have not lost a pressure in the gas, you will not have wouldn't have this complication. The last thing is that did you try? I'm sure you tried pull the rotablator sort of with traction before you put in the extension.
Yes, we tried and it was unsuccessful. Yeah. So so that's why we went.
actually, I saw from the video that actually the guide extension actually did not go in very far. It's only right at the proximal LAD. So it means that the guide extension may not have helped so much, because if the guide extension has gone down right to the burr, then it may have more force to pull it out. So in this case, I'm just wondering whether you're there enough to put a bit stronger. It could have come out without the guide extension.
Yeah.
And the other thing is that it doesn't matter whether it's 6 French or 7 French, because as long as you can get the burr out from the artery, it will go into whatever 6 French thing is here. Yeah.
Aaron,
okay, that's my.
Good afternoon, Aaron. Eric here. Maybe I'll briefly ask Emanuele if they have any comment on this case, Barbato.
Yes, thank you. Actually, this was a very nice case, and I guess the colleagues handled that very well. I was listening really with interest to the comments on the case. I would have personally not started with balloons in this case. Much like the colleagues, I would have started with rotational atherectomy. We know this long calcified lesion, even if you can dilate them with non-compliant balloon, the plaque is never appropriately modified. So I would have started with rota as well, perhaps with 125 millimeter bar in this case rather than 1.5 for a number of reasons. First of all, low ejection fraction. We know that with bigger bars, we can generate more shower of micro debris. We can have higher chances of no reflow. So 125 millimeter bar. In addition, the technique in long calcified lesion should be slightly different as compared to focal lesions. So really, ideally, cut the coronary segments in multiple pieces and tackle them stepwise, one by one, in order to minimize the risk of bar entrapment. But on top of all this, the colleagues applied a good technique, and they had just the bad luck that the gas was compressed, the tube of the gas was compressed. That was really like a Murphy's Law. They applied all the care and all the caution in this patient. They put balloon pump, they used a big bore guiding catheter, and nevertheless, there was something from outside that really messed it up during the case. In the number of troubleshooting tips and tricks, perhaps what I would attempt first is simply to pull gently on the rota wire. We know that the radiopaque part of the rota wire is thicker than the shaft, and that works as a distal anchorage. Not forcefully, just pulling back a bit, and then once the radiopaque part of the wire is at the level of the burr, pull both the shaft and the wire together. This sometimes is sufficient to disentangle the rota bar, but the rest I would have done exactly like the colleagues.
Thank you, Emily. We give the floor back to you, Paul and Jack and Aaron.
Thanks, Eric. That was great comments from everyone. The only learning point I have is always check your gas before you drive off. So that's always a common problem when you know it's going to be a long case. You under pump your gas or check your gas tank. So I'm going to introduce Dr. Pinakin from Woodlands Health Campus. He's going to present a different track and a slightly different coronary complication. Pinakin, please.
All right, thank you everyone. I've got 7 minutes to present, and we know haste makes great waste. So I'm just going to quickly dive into the case. This is a 60-year-old female Malay lady who's got the cardiovascular risk factors. Again, she's end-stage renal disease. In December, she had triple vessel disease in another institution. She was a surgical turndown, and PCI was already being planned for in the outpatient setting. She had an unscheduled admission for NSTEMI in my institution, and I took on the case. So this was her pictures. This is the left-sided shots. The ostial circ is heavily calcified. There's also ostial LAD disease. So there's a bifurcation disease at the left main there. The ostial RCA was severely diseased. There's pressure ventricularization here. So my strategy was quite clear. Quickly settle the right with a short focal stent, and then go on to the left to try to dilate that nasty ostial calcified circ lesion and maybe even the need for rotablation. So I used the AR1 guide with an anchor wire because this was ostial positioning of the stent, NC balloon, scoring balloon, dilated it quite well, put in a 30/36 DES, and the right picture is the picture after the DES. The stent looks okay, but there's this luminal loss in the LA in the RCA with a TIMI-1 flow. It did not improve with GTN, and I was worried whether there is a distal stent edge dissection that spiraled down all the way. So I decided to post-dilate the stent with a 3.5 NC, and my intent was to deliver a 30/38 stent and cover the dissection edge and overlapping with the prior stent. Stent went in, it could not advance in the stent. Maybe I needed to do more post-dilatation. I withdraw the whole system, and the next thing I knew, the stent balloon had come off without the stent. So this is the next picture I had amidst all the chaos. Just give you a few seconds to appreciate this. And I've got a pictorial representation which I drew for you. So basically what has happened, the blue is the guide, the red is the coronary artery, there's the black original wire in situ, the light blue is the deployed stent, and the second stent that I was trying to deliver has stripped off, and half of it is in the coronary artery, half of it's in the guide, and my aortic wire has also telescoped in a looped fashion, and I think it was tangled together with the stripped stent. So I think the two problems here, that aortic wire tangled with the stent and also the stripped stent. So at this point of time, I wanted to only deal with one variable at a time. And my first aim was to try to withdraw this wire, this aortic wire, out into the aorta and see what is the interplay together with the stripped stent. So by doing so, unfortunately, the guide got dislodged from the proximal edge of the stripped stent. The aortic wire is actually twined together with the proximal edge of the stripped stent, and it's moving forward and backwards as I push and pull on this wire. So this is basically a stent loss, and I needed to retrieve the stent because it's in the ostial position. Half of it is into the aortic root, and I've got wire position maintained. There are a few techniques that we know of: the small balloon technique, the stare, or even a guide wire twirling technique. This is from Brilaki's Manual of Percutaneous Coronary Interventions. So since I had the wire, I had the option of putting in a small low-profile balloon through the strip stent over the wire, but I was worried whether the balloon could even pass because the whole stent was very elongated and very flattened, and I did not want to push in the stent any further. And part of the stent was in the aorta, so I don't think there was any support to introduce the balloon. So my aim was trying to snare this. So I never wanted to lose guide wire and a guide position. I was worried by snaring I might lose the whole system. So I used the ping pong technique to try to introduce another wire into the coronary artery so that I have ready access to the vessel if I caused more complications. You know, sometimes complications come in a series. And the other thing was, if you wanted to snare this proximal stent edge, it's very difficult to snare with that aortic wire twanged together with the proximal stent edge. So I tried to pull that wire with the support of a 1.5 balloon and managed to free that wire away from the proximal stent edge and remove that whole wire altogether. So what I had in my cath lab was only a peripheral snare. So I took out this gooseneck 5 mm snare, and this snare comes in two pieces. There is the snare wire itself, which is 120 cm, and the sheath for the snare to be railed in. But this sheath is only about 100 cm, and that's the length of your guide catheter. So you either cut your guide or you do away with this sheath and use your guide itself as the sheath to rail in your snare. So I've got my second access with the wire there. I even had a balloon, 2O balloon, distal to the stent just in case I needed to secure the whole system. But nevertheless, I was still losing guide wire position with the original wire. So I was trying to snare the proximal edge of the stent. And after multiple tries, I managed to do so. And on this right-sided picture, you can see the snare has been anchored. I pulled on the snare on one hand, and I also advanced the guide with the other hand. And fortunately so, I managed to advance such that it darted forward and engulfed the whole dislodged material as if like how a python engulfs its prey. So next picture, you can see the entire dislodged material is within the guide. And so there's no worry about this dislodged material getting stuck at the 6-strand sheath, which I had from the femoral artery. So I took out the whole thing en bloc and finished up the rest of the procedure by guide liner extension now. I did not want the stent to get stuck again. So guide liner got the Trio 38 stent down and finished the procedure. You can see here, the original stent seems to have foreshortened and crumpled upon itself, likely from the impact of the earlier stent. And this is what I took out en bloc, this very elongated stent deformed totally. So, this is quite a routine thing that we can do to remove a snare. I think my main message is, we can go for conferences like this to learn about techniques. We can read this from the books, but the real deal, I think the real deal for me was when you have a master tutor who comes together and teaches you all these techniques in a hands-on session, that will really make a world of a difference. This was my first dislodged stent as an independent operator. And just 1 month prior, I had the good fortune of attending a masterclass where Dr. Paul Ong came together with a few junior colleagues of his and taught us all the tips and tricks and strategies to deal with these complications in real-time models. It made a huge difference. So thank you, Dr. Ong, and thank you, everyone.
Thanks, Pinakin. And that was great and a great save, actually. Great final results. Hua, any comments about the case?
Yeah, thanks, Pinakin. I think it's a very nice case that you showed. And then I think Paul has definitely taught us a lot in the cath lab. And we all, over the years, have learned. First of all, we all learn from each other's complications. I think for your case, just want to comment, did you consider imaging for the, the stenosis that appeared after you did the ostial to proximal stenting? At any point would you consider, because it could be spasm or it could be dissection, like what you said?
Correct. So, I did consider the imaging, but when I took more and more pictures after GTN, it somehow got worse and there was some dye staining noted at the distal assay. So I was just worried it was a spiral dissection and I did not want to introduce a catheter. I wanted to secure the vessel before I lose the vessel totally. It was really TIMI 1 flow.
Yeah, no, I think your case is very nice because I think a lot of times whenever we all stent the ostial RC, I think if our stent stretch out a little bit, we have a hard time to deliver a second stent more distally. I think your case illustrates that point. So I think it's important to post-dilate the ostium very well and never lose the guide like what you said. And perhaps looking back, maybe I think you will consider using a guide liner to deliver a second stent down, I think. Yeah. So
that's usually my routine practice, guide liner. But somehow this one, there was poor TIMI flow. I was quite confident I dilated it quite nicely with the 3.5. But then again, calcium, you never expect it. It bites you hard when it needs to bite you.
Dear colleagues, we have also in remote Evgeny Merkelov, who is in Moscow, watching the session as a co-chair. Do you mind if I ask you, Evgeny, if you have any comments on this case?
Thank you, Eric. The case looked very simple first, like a short lesion, preparation and one stent, and then out of the blue, this stenosis or dissection or spasm distally to implanted stent. And first of all, I'd like to mention that I agree with previous doctor who mentioned that it's really important to understand what is going on with the artery below the implanted stent. Maybe it was just a spasm and you didn't need to put another stent and you could avoid this complication. And I personally think that it must be proved that this lesion has to be stented, and IVUS would be necessary in this kind of cases.
Agreed.
Thanks a lot for that comment. So,
sorry, just
Aaron,
one comment. So I suspect this probably could be a hematoma. The appearance looks like a hematoma. So like everyone mentioned, the IVUS, put it down, could be a good technique to see what to do next to save you from this stent dislodgement. And the other thing is, I'm a bit conservative. I think the stent size of 3.0 may be a little bit too big for these vessels. Maybe not for the proximal, but the mid part may be a bit too big. So maybe there's a dissection there that causes the hematoma.
Thanks, Aaron. Any other teaching points from the rest of the faculty for this case?
Yeah, I have some comments. I think it's always very tricky to go through a freshly stented segment, which is angulated and somewhat calcified, because you never know how well the post dilatation is with regard to actually optimizing the stent for the second stent delivery. And I think the confounding factor was also with the wire in the aorta. So there's actually quite a lot of device interactions here. And with more devices, your stents may just get caught in the wire wrap. And in this case, also, I suspect it's actually at the distal stent edge. There could be some segment which is actually really angulated, which is causing the stent to be stripped off. Now, the techniques for retrieval of a dislodged device, you've very nicely showed. And I think the saving grace was that you still have the wire in. And I think that if we were to start off with the twirling wire technique, that's, I feel, the success rate is not very high, and that would actually lose the wire. So I think in this case, going for the snare was the appropriate choice, where you still had the wire in, and the snare could actually go onto the wire and retrieve, the
you have to direct it towards that.
Yeah. All right. That's my comments.
Thanks, Josh. Paul, you were training everyone. Any learning points from you then before we go on to the next case?
I think I was just facilitating. Okay, so Pinakin obviously is now the real deal. But I think it's I think for all of us, when complication happens, it tends to be the most senior person very quickly snatch the case and take over. And a lot of us kind of only get to see it. So some of the sort of hands-on workshop, actually physically touch those devices, play with the snare, try on all these techniques is actually very important. And I think when you are actually the one facing it for the first time, it's just so reassuring that you already know how to use this coil and knows how to use this snare. But I think it's a beautiful case Pinakin's presented. So if there's no other comments, maybe we can invite the next speaker on.
Can I just make one very fast comment? Sorry. Yeah, I just realized that when Pinakin, when you put in the second stent, actually the second wire in the aorta is not needed, because if you put it there, the guide support will be not so good. So that's why the stent may not be able to cross. So you actually need to engage the guide into the stent in order to deliver the second stent.
Correct. Yeah.
Yeah. Okay. So I think now can I ask maybe Jia-Min to present her case. Dr. Jia-Min is the clinical fellow from Tan Tock Seng Hospital in Singapore. So she's going to present a case of the twisted tail of two guiders. Over to you, Jia-Min. Jia-Min is also from Tan Tock Seng Hospital, my old hospital.
Hey, hello, good afternoon, everyone. I'm Jia-Min. I'm a fellow from Tan Tock Seng Hospital in Singapore. Today, I will be presenting a case whereby a guider was completely fractured during primary PCI and was retained in the ascending aorta, and how we use a novel method to retrieve it. The case begins with a 94-year-old male with background of diabetes, hypertension, and hyperlipidemia, who presented to the ED with an anterior STEMI. We brought him to the cath lab for urgent primary PCI using a radio access and an IL-35 guider, and the usual antiplatelet anticoagulation regime was given. We encountered resistance just shortly after advancing the J wire, and an angiogram showed a tortuous right radial artery with a focal stenosis just proximal to the cubital fossa. We successfully brought the IL-35 guider up to the aorta. However, when we attempted to engage the RCA, there was loss of pressure tracing and difficulty in manipulating the catheter. Fluoroscopy of the right arm showed that there was knotting of the guider just proximal to the cubital fossa. We tried to untwist the catheter by inflating a blood pressure cuff and using direct compression just above the level of the knot. However, when we delivered an untwisting motion to the proximal catheter, there was a give, and the catheter completely fractured at the twist. So the fluoro images show where the catheter had broken off, with the proximal tip of the guider in the radial artery and the distal tip of the guider in the ascending aorta. The last illustration shows where the catheter was left in the body after we removed the proximal part of it through the radial sheath. We decided to proceed with primary PCI first and then come back to retrieve the fracture guided later. We switched to a femoral approach with a 6 French femoral sheath and an XP3 guiding catheter. Angiogram images showed that the culprit was critical lesions in the proximal to mid-LAD, and the circ and RCA were quite unremarkable. We proceeded to do successful PCI to the LAD with appropriate post-dilatation. Next, we turned our attention to retrieving the fractured catheter that was still in the aorta. We opted to do this via a transfemoral approach. So we upsized the 6 French femoral sheath to a 9 French long 35 centimeter sheath. And we went in with an XP2 6 French guiding catheter. We self-improvised a snaring device to bring the catheter to the femoral sheath. And how we did it was by introducing the wire as a loop into the guider. We brought the loop all the way to the guider tip. We introduced a balloon to the guider tip and inflated it to trap the wire tip. And then this allowed us to create a snare with an adjustable loop diameter. So this pictorial shows us what is inside the guiding catheter with a trapping balloon trapping the wire tip and allowing us to have an adjustable loop diameter. After a few attempts, we managed to snare the distal end of the IL-35 catheter and put it down to the descending aorta, but it was unable to enter the 9 French femoral sheath because it was not coaxial. So this is a video showing us pulling the IL-35 catheter down to the sheath, but because it wasn't coaxial, it did not enter the sheath. We observed that actually both the IL-35 and the XP2 guider tips were touching quite frequently, and it suggested that they were in quite close proximity to each other. And we confirmed on several views that the tips were actually aligned. So we removed the snare and introduced a Sion blue wire via the XP2 guiding catheter into the aorta and retrogradely advanced it into the tip of the IL-35 guiding catheter. We then used a short 2 to 5 10 millimeters balloon inflated in the IL-35 guiding catheter to anchor it and managed to pull it to the tip of the femoral sheath. However, again, it was not coaxial, with the catheter edge abutting against the edge of the sheath. So this shows the misalignment where the edge of the catheter was abutting against the edge of the sheath, and therefore, again, the guider did not enter the femoral sheath. We then replaced the short balloon with a longer 30 millimeters balloon and inflated the balloon such that half of the balloon was within the IL-35 fractured catheter and the other half was exposed outside the catheter in a setup that was similar to the balloon-assisted tracking technique. The balloon was then inflated, and when it was withdrawn, it conjoined the entire IL-35 XP2 guider together with the sheath. So everything was aligned and allowed for successful removal of both the guiders. So this picture illustrated how we used the balloon-assisted tracking technique, where half of the balloon was within the catheter and half of it was exposed outside. And this aligned the entire system so that the catheter could be removed smoothly through the femoral sheath. And eventually we used an angioceal closure device upon removal of the femoral sheath. So in summary, we illustrate a case where IL-35 guider was over-twisted and completely fractured at the right radial artery with its distal tip in the ascending aorta. We successfully retrieved it using a femoral approach with a large bore sheath, using a self-improvised snare to bring the fractured guider close to the mouth of the femoral sheath, retrogradely wiring into the fractured guider catheter, and using a balloon-assisted tracking technique to align the entire system together and allowing smooth retrieval with no vascular complications. Okay, that's the end. Any questions?
Wow, congratulations, Jia-Min. This is actually a showcase of innovation on the table. And I like the fact that, it was proceeded in a very stepwise fashion. Your priority was the AMI. So even if the catheter was untwisted and fractured, you performed the primary angioplasty smoothly, and then go to retrieve the fractured elements. I think you've shown quite a number of techniques. The first being the self-made snare. We all read about it, heard about it, played with it on the bench, but this is actually a very nice showcase of it. And you face the problem of actually retrieving the fractured catheter out of the large bore sheath. So actually with any retrieval, in my cases, if I put a large bore sheath from the groin, I would actually make a bevel at the sheath. That means the sheath will not be actually circular at the tip, but actually I would actually cut it in a bevel shape, and then introduce the dilator and then advance the sheath in. The bevel works because it actually allows a bigger surface area for any of your devices, that you retrieve to be retrieved. For example, even an embolized PFO closure device, or one of the plugs can be successfully retrieved with a beveled tip at the femoral sheath. But I think on the table, you tried various techniques which were very elegant to align the fractured catheter to your the retrieval catheter, so that everything is coaxial to come out together at one piece. And I particularly like your balloon-assisted tracking. I think that is very, very elegant, using a long balloon to just basically align everything. So congratulations. For my other panelists, if you have any further comments.
If you allow, just a very short comment here from Europe. Indeed, I must say that when we saw this procedure done by you, basically I saw Thierry just raising up his hand and giving a sign of congratulations. So maybe Thierry, you want to give a small comment on the case. It was elegant. You were exactly resumed the whole situation perfectly.
Yeah, I think it was really a great case and a very nice demonstration of innovation to solve a complex issue. At the same time, I will encourage everybody to prevent this kind of complication. So because we have seen another one yesterday, just due to the fact that you have problem to advance the guiding catheter and you make one twist, two twists, three twists, and at one time you are not able to remove it. So very important to be careful when you start to rotate the guiding catheter knowing in which direction you are doing that, and then you just have to untwist at the same time in the opposite way to solve this issue. But congratulations for this very elegant solution to this problem. And thank you.
Thanks, Teresa. That was a very good comment and teaching points as well. I thought it was very elegantly done. I think I echo Teresa's point. Most times, if you're going with a primary guide for PCI for the radial approach in an elderly lady, you expect some tortuosity. I tend to leave the 035 guide wire in to prevent this twisting from happening, and it also helps you engage a little bit easier. But I think the approach and how this case was handled was superb, and I think it was a really good step-by-step on-the-spot remedy of the very tricky situation. So I think in the interest of time, we'll go on to the last case, a structural complication, transiting a little bit. We'll have Dr. Kay Woon from the National Heart Center present his case. Thanks, Kay Woon.
Thanks, Jack. So it's going to be short and quick. This is the title of the talk, The Day When XT Implantation Meant Extra Trouble, ×3. So a typical lady, 86-year-old with severe symptomatic aortic stenosis. The echo confirmed severe AS with normal ejection fraction. CAF minus CAD. STS score not high, less than 4%, but she was deemed high risk for open surgery because of ascending aorta calcification. I don't have the CT because it's been archived, but the femoral artery size were good. We were planning to go from the right side. MLD was 7.2, some calcification 180 degrees. The coronary heights were good, left main 12 millimeters and right coronary artery 22 millimeters. The annulus averaged about 26 millimeters in excess of that. And our primary excess was that of the right. So this was a CT scan. You can see the calcification and some amount of tortuosity. We were planning to use Sapien XT29 deployed at nominal volume. We were still doing cases under GA and TE guidance for all cases. So we started off with puncture, ultrasound, or this is fluoroscopic guidance. We had problems deploying ProGlides. Multiple ProGlides were used, but because of calcification and tortuosity, we're not able to deploy the ProGlides to pre-close. And we actually had a crossover angiogram before we transited to a surgical cut down just to make sure that we have not caused any injury. So this was good. We then went on to a surgical cut down to control the excess and confirm again on peripheral angiogram there were no injury to the more proximal vessel before the decision to proceed on with transfemoral TAVI. The E-sheath went up reasonably well, and this was ascending aortogram showing the coplanar view for deployment. Note also of the RCA, good flow, as well as the left main good flow. This will have implications later. We pre-dilated with a 25 millimeter kit balloon. The balloon slipped several times at a pacing rate of 180 beats per minute. We had to increase the pacing rate and very slow inflation. The corresponding TE image of the balloon inflation was as shown here. This was the TE image showing some AR after balloon pre-dilatation. Patient was stable. When we tried to deliver the XT valve, we actually had a lot of resistance and difficulty moving. This was surprising given that MLD of the right side was 7.2. So how this was overcome was to withdraw the sheath, advance the valve, then advancing both valve and sheaths to facilitate going past that resistance. So we found a reasonably good position for deployment, rapid pacing at 200 beats per minute, and very slow inflation with the corresponding TE shown below of the 29 XT valve. This was deployed at nominal pressure and volume. You see good expansion of the valve frame. And the balloon came down, rapid pacing was taken off. So we thought reasonably good deployment. That's the end of our day. However, patient turned hypotensive. New bundle branch block was noted with inferior ST elevation. So TE showed inferior hypokinesia, whereas we can see the left main, the right coronary artery was gone on the aortogram. The TE showed some central AR with the YSU in place. This was not surprising. She deteriorated very quickly. CPR had to be commenced with placement of ECMO cannula. So that gave us time and some stability to investigate what happened. We first searched out the left main and then the right. Because of the horizontal aorta, this was a little bit more difficult, but you can see there was a filling defect of the RCA. We searched around at the sinuses to see whether there were any causes. We don't see any filling defects. The differential diagnosis was that of a clot as well. Again, we don't see any filling defects nearby. Notice how the position of the XT valve was actually quite far away from the RCA ostium. Eventually, we transited to change several guides, eventually deciding on the AL 0.75. Even that required a bit of manipulation, got the guider somewhere close to the ostium, and remotely wire the RCA. We then implanted a stent at the ostium of the RCA. The ST resolved and the blood pressure stabilized. We thought that was the end. E-sheath was removed, surgical vascular repair was done. However, blood pressure was low again, and with ECMO, the flow was low. We know that this signaled volume loss. But where was this volume loss and hypotension? So we redid all the steps, aortogram. We can see patent coronary arteries, both of the left main and RCA. But I want to draw your attention also to this radio-opaque line of where the pericardium is. There seems to be some staining of the pericardium and contrast. We turn to the TE, there was thickening of the ascending aorta, suggesting there was some hematoma of the ascending aorta, together with the contrast in the pericardium, suggested there was root injury, possibly because of oversizing of the XT valve. However, we felt that was not sufficient to explain the hypotension. We went on to do peripheral angiogram, and we saw contrast extravasation of the right external iliac artery together with a dissection. So you can see the dissection and extravasation. We balloon tamponade, however, this did not stop the contrast extravasation. So we had to place a covered stent. This was the position of the first covered stent, 8x40 balloon expandable covered stent. This was the result after the first covered stent. There was still continuing extravasation of contrast. So we had to place a second covered stent in an overlapping manner. And after the second stent, there was still contrast extravasation, although that was better. We post-dilated this. And this was the result after post-dilatation. Still a little bit of extravasation, but at this point in time, the blood pressure stabilized, ECMO flow has been increased. The decision was made for conservative management. CT post, compared to pre, we can see there was accumulation of fluid around the pericardium. There was no report of any ascending aorta hematoma, but this correlates with possible aortic root injury. The CT also extended to the femur where we see hematoma, but no active contrast extravasation, suggesting that the covered stent was adequate in preventing further contrast extravasation. Progress of the patient, she had massive blood transfusion. ECMO was fortunately weaned off at day 4. She had complications of both PE as well as pneumonia during the hospital stay, which she stayed for 1 month before transferring to a community hospital. 5 years on from this procedure, she is now 91 years old. I just saw her this year. Valve is fortunately still working very well. So summarizing the procedural challenges, failure of proglides due to tortuosity and calcification, we dealt with surgical cut down. Difficulty getting the XT stent past the E-sheath to pull back and manipulated the E-sheath. There was RCA dissection and occlusion, possibly slippage from the pre-dilatation balloon, or more likely oversizing of the TAVI device, which was about 18% oversized. This was overcome by ECMO support supporting the blood pressure, RCA stenting, root injury. This was managed conservatively, and the peripheral dissection and perforation managed by balloon tamponade and covered stents. Lessons learned: TE now is trendy not to do TE in routine TAVI cases. I still find it very important. So routinely, even in the LA sedation cases, we have pediatric TEs. This alert us to any urgent assessment. prompt diagnosis and treatment can make a difference between life and death, and the importance hence of bailout devices available. Now we know that proper sizing and deployment, especially of balloon expandable valve, is important, and the decision maybe to underfill the balloon may avoid the aortic root injury in this case. I thank everybody for your kind attention.
Thanks, Kay Woon. Very, very nicely presented and a good save. I wonder whether my European colleagues are still on the line, whether they can offer some comments first.
We are there, Jack.
Of course.
Yeah, Eric, can you and your team from Europe give some comments first?
Yeah, I think maybe both Emmanuel, maybe also, let's start with Evgeny Evgeny maybe Evgeny, first, yes. And then we will...
And David.
Yeah,
is David back?
I think it's very elegant,
David.
Elegant way how you managed to work with this complication. My concern is that you place 2 graft stents, and it will be definitely then restenosis or maybe occlusion. Would you consider to ask surgeon to help in these cases, or it's necessary to stabilize the patient and stop leakage first, and then maybe decide about future procedures?
So the surgeons were there every step of the way. They felt at her advanced age and instability that it was best for a covered stent. In retrospect, 5 years on from the case, she didn't have any problems with the covered stents. So in retrospect, probably a correct decision.
So maybe maybe introduce David Kildee-Smith, who is with us. So David, you want to make some comments?
Yes, amazing case. So many complications, and yet you managed to salvage it. So that's brilliant. One comment about the covered stents, actually. Right at the start, the surgeons, particularly the vascular surgeons, always told us, oh, no, you mustn't put covered stents here. They'll bend, they'll break, they'll clot. Actually, with all the covered stents we've put in, I've never had some come back with a major problem. And I don't know if Thierry or Eric, whether you have, but I've been sort of surprised and pleased how little trouble there's been following the use of a covered stent, although we were always warned about it.
Yeah, I fully agree, David. We had exactly the same experience in Massy. So we never had a patient coming back due to problem with covered stent. So I think it's really not an issue. But did you have this kind of complication of this occlusion of the right coronary artery, something that we have never seen in my center? We have done now more than 3,000 TAVI cases, and we have never seen this kind of complication. So what is your opinion?
I don't know. I mean, maybe there was some oversizing. Maybe there was some dissection that went into the right coronary. Maybe there was some debris went down it. I'm not really sure, I'm afraid.
It's not clear now.
Yeah, what was not shown was that there were several attempts at pre-dilatation. The balloon went back aortically. This was a kit balloon, 25 millimeters, possibly a little big. And every time it went back, possibly there was some injury to the RCA.
It's true that...
make an announcement first. Paul,
go ahead.
Yeah.
I think while we're discussing the case, I want to remind everyone that we also need to pick the winner. I think we have 4 brilliant cases today. So while the discussion is ongoing, I think the organizer wants us to announce that there are some voting going on to pick the best case out of 4. Just a quick reminder: the first case was a case of an entrapped rotablation burr, how to retrieve it. The second case is a dislodged stent, and how that was removed successfully. The third one was a fractured guiding cath, and how that was again retrieved via the femoral approach. And then the last case was structural heart, talking about the RCA problems and also the femoral artery dissection and sealing. So please carry on the discussion, but please log on to the web page to do the vote, and also the panelists among us. Also, we need to get the feel of who is the best case. This is the cases. Just a quick reminder. First case by Hui Wen on the rotor. Second case by Pinakin on the dislodged stent. Third case, Jia-Min with the fractured guider. And case 4 is Kay Woon's case of the TAVE case. Sorry, okay, please carry on with your discussion on this case. I think it was very rude of me to interrupt.
Thank you, Paul. It is true that these vascular complications that may occur in the setting of TAVI introduced us, at least interventional cardiologists who are not keen or used to peripheral intervention, to use this cover stent in the peripheral circulation. So for us, that was a good move, I must say honestly, because we learn how to use these bigger devices. If you're not used to use it, Emanuele, how is the practice in Aalst?
Well, we do implant covered stents. We are actually fortunate because we have a hybrid team at the table. There is always the cardiac surgeon who is also vascular surgeons with us and who's ready to jump in case of problems, much like they did with the colleagues over there. But there was one aspect of their procedure that captured my attention when he mentioned that at the first glance, he couldn't. At the first attempt, he could not advance the XT valve within the sheath. Then he had to pull everything out, and he pushed consistently the valve and the sheath. Now, this E sheath that might open up when pushing the stented valve inside. So I wonder whether this dissection at the level of the iliac artery might have, in a way, facilitated by this maneuver, consistently pushing the valve and the sheath together. But I have no experience with that, and I wonder whether this might have been one of the mechanisms facilitating this dissection in the iliac artery. Because if I recall well, this sheath opens up and closes again. So.
Yes. I think we all know when we always make a joke about when we introduce these big valves into the E-sheath, how physically demanding it is. You really need force and power, and we let the valve advance through the E-sheath. What we were told by Edwards Company is to leave a little bit of the E-sheath out, because if there is vascular disease and you really get stuck with your big valve into the sheath, you can use this small part to go inside, and when you go posterior and you get the whole thing more inside the sheath. And this is a trick that they teach us to really get the valve in. I think some of you, at least we already had almost kinking of the delivery sheath while we're trying to push this very, very tough big valves through the E-sheath. And a 29 valve in an Asian patient is that rather rare, Jack, in your practice? Rather rare, no?
Yeah, not so common for elderly aortic stenosis, but possible. Kay Woon?
Yeah, we usually will implant either 23 or 26 sapien balloon expandable valves. So 29 is rather rare. Probably in retrospect would have underfilled, knowing what we know.
I just a quick backwards comment about asking surgeons to fix such complications. I think experience in peripheral is that if you do have a iliac artery rupture, is usually a life-ending maneuver, and you do have to sort it out percutaneously. The surgeons can't get there fast enough to save the patient. So a covered stent is a quick bailout and life-saving measure that is used quite commonly. I wanted to ask Kay Woon, when you saw what's called the pericardial effusion, the drop in blood pressure, I saw that in retrospect, it was a good decision not to think that was the only cause and check elsewhere. But you decided not to drain it as well, right? Actually?
Yeah, it looks small. The hematoma, or what was reported on the echo, was small. We had echoes confirm that this was small as well. We had the ECMO in place. The ECMO showed low flow. So it was blood loss somewhere. It was not due to the pericardial effusion.
Thanks, Kay Woon.
Paul, do you want to come back to the vote?
Yeah, we need to come back to the vote, whether the hosts and the organizers have a chance to see what's the vote count like.
Okay.
Logical. So I think a lot of people really like Dr. Chua's novel technique. Showed a lot of quick thinking on their feet and a lot of innovation. And I really learned something as well that's new. from looking at the case. So I think I would agree with that. Would my panelists and my co-chair have any comments to this vote? I would agree with the voting that was voted online.
I think we all agree. Maybe we'll give the final words to you, colleagues from Hong Kong. Maybe a short roundup here from Europe. Maybe Emanuele and Thierry.
Yes, actually, I agree on the poll. That was indeed a great case with the collection of tips and tricks, innovative solutions. So congratulations to the winner. We look forward to, the winner will come over here next year. That's the prize, right? So we look forward to meet the winner next year here in Lausanne on the lake.
Thank you.
So thanks.
Thierry, no comment?
Thanks a lot.
Okay, we'll give the floor back to you, Jack and Paul, to say some closing remarks, and then we will end the session over here. Once again, I think this. I think it's essential to highlight again this long-standing relationship and friendship with all of you in Singapore. I think you are lucky. You're living in a kind of mini Switzerland, and enjoy life over there. I think you should continue. And I think what you demonstrated in this 90 minutes hub transmission was just perfect. As always, very well organized, to the point, on time. And I just did a humble contribution with my lecture, which was really not needed. So I give the final words to you, Jack and Paul.
Paul?
I'm not sure there's actually a lot more to add, except that, I really treasure the friendship that we have. Nice to see all of you again online, but, we really couldn't wait to actually pay a visit again, Eric, back in Switzerland next year.
Thanks, Paul. And from my end, I'd just like to thank the time from Europe, the ECC hub, as well as my panelists and my presenters. We're very glad of the generosity from ECC to offer this travel grant to the winner this year from Singapore. And I think we can't wait to get out of Singapore to come and join you in Luzon next year. Thanks, Eric, for the opportunity, and keep safe, everyone.
Thank
Goodbye.
you. Thank you. Bye-bye.
And thanks, everyone. Okay.
Thank you. Bye-bye.
Bye. Take care. Bye-bye.
So this brings us to the end of this Singapore session. We have a short break where, in fact, there will be space for the satellite short breaks with the industry. So this will be ongoing now, and we will come back to you in a short time, in about 5 to 10 minutes. See you then.
Hello, and welcome to this Biotronic Technology Update at ECC 2021. Thank you for joining us. I'd like to spend a few moments to walk you through the Biotronic portfolio for complex PCI. So over recent years, Biotronic has invested heavily in bringing to the market a very robust and comprehensive portfolio to support percutaneous coronary interventions, from drug-eluting stents, drug-coated balloons, covered stents, guide wires, and balloons. Hello, and welcome to this Biotronic Technology Update at ECC 2021. Thank you for joining us. I'd like to spend a few moments to walk you through the Biotronic portfolio for complex PCI. So over recent years, Biotronic has invested heavily in bringing to the market a very robust and comprehensive portfolio to support percutaneous coronary interventions, from drug-eluting stents, drug-coated balloons, covered stents, guide wires, and balloons. We offer a very robust portfolio, all supported by a significant and robust amount of clinical data. One of our most recent innovations is the Orsiro Mission, which really brings the next level of deliverability for the well-known, well-loved, and well-studied Orsiro stent, with more than 55,000 patients enrolled. We completely re-engineered the Orsiro Mission delivery system to give increased flexibility with the shaft, to give much higher trackability. And we also improved the embedding of the stent to ensure much higher crossability, especially in those demanding calcified, high-grade stenoses. So far, the acceptance of the Orsiro Mission device has been excellent, and we hope you have the opportunity to try it in your lab in the near future. One further product that's very interesting for physicians performing complex PCI is the PK Papyrus covered stent. Thankfully, complications in PCI are rare, but when they do happen, they can be life-threatening. PK Papyrus is a single covered stent design, which has extremely high bending flexibility and a very low crossing profile compared to traditional sandwich stent designs. This utilizes the well-known prokinetic energy stent backbone covered with electrospun polyurethane fibers. And this device, because of its very low profile and exceptional deliverability, really gives physicians a very quick and reliable way of dealing with coronary perforations. One clinical study performed actually showed that the PK Papyrus took 47% less time to deliver than a traditional sandwich stent design. Biotronic is also proud and excited to expand its offering for complex PCI by partnering with IMDS in certain markets in Europe. Biotronic is the exclusive distributor of IMDS in Germany, France, and Switzerland. IMDS really offer a very comprehensive toolbox for complex PCI. Here we see on the left, for example, the Gideon Hydro guide extension catheter, designed to give really excellent backup support for physicians wishing to reach and treat those more distal, tortuous vessels and lesions. IMDS also offer the Enhancer family of microcatheters, here the Enhancer RX dual lumen catheter, and also the Enhancer Pro X support catheter on the right side here, designed for retrograde crossing and to give excellent guide wire support. The Blimp CTO crossing balloon is a low-profile balloon designed to cross balloon undilatable lesions in CTO settings. IMDS also offer the Trapit, a trapping balloon designed to sit inside the guide catheter and to be inflated during device exchange to maintain guide wire position. And one of the devices that's really gaining a lot of interest in the community is the unique Recross over-the-wire dual lumen catheter. This device has 2 over-the-wire lumens and 3 exit ports, 1 at the tip and 2 on the shaft, 180 degrees apart. This device is really designed for a myriad of complex PCI procedures. For example, those physicians wishing to use the antegrade dissection reentry technique, for example, for hematoma decompression, and also for anchoring in side branches for extra support. Now I'd like to introduce a short video on the Recross from IMDS.
In this instruction video, we will show you how to use the unique Recross over-the-wire dual lumen microcatheter with 3 distal exits. The device can be taken out of the hoop and should be flushed in both of the over-the-wire lumens. This can be done either inside or outside the hoop. The blue hub comes with the stylet inserted. Take it out and flush that lumen as well. Bring it back in and use it during insertion of the Recross device. The stylet gives higher pushability during insertion and advancement of the device. The white hub is connected to the tip and to an additional exit port number 3. So the white hub, which is mentioning tip, is connected to both the tip and the proximal exit port. The guide wire should always be slightly shaped, and depending on the rotation of the guide wire at the proximal end, it will come out of either the tip or the proximal exit port. When the stylet is inserted in the blue hub, there's no space for a guide wire. Take it out and flush the lumen in order to bring a second guide wire through the blue stylet lumen. That guide wire will come out of the middle exit port, number 2. So 2 stands for blue. A torque can be used on both of the guide wires in order to rotate them more easily. Both the exit ports are positioned 180 degrees opposite to each other, so they are allowing almost 360 degree access. The Recross can be inserted together with the guide wire. Backload the guide wire from the white tip hub. The guide wire should always exit the tip. So not exit the proximal exit port, it should always come over the tip. Insert the Recross plus the guide wire through the hemostatic valve into the guiding catheter. When the guide wire is already in place, it is very useful to use a trapping device like the Trapit in order to keep the position of the guide wire. Bring the trapping balloon inside, inflate it, check if the position of the guide wire is locked. Then insert the tip of the Recross over the guide wire. So the guide wire is going through the full over-the-wire lumen of recross, the white tip lumen, and not exiting from the proximal exit port. Follow the recross with the tip over the guide wire. The black markers indicate whether the tip of the recross device is exiting the tip of the guiding catheter for either the 90 cm or 100 cm guiding catheter. Deflate the trapping balloon again, take it out. The proximal end of the guide wire is exiting from the white tip hub, as you can see, and advancement of the recross device can be continued. Recross is a device that should be pushed over the guide wire, so it will slide over the guide wire. Its shape is not allowing fast spinning. Slow rotations are allowed in both directions, but if the torque tension is increased too much, it is important to stop because the forces will be too high. The recross is versatile and multifunctional. The cross sections show that the shaft is ovally shaped, and the exit ports are positioned in such a way that they are facing up and down, and this design facilitates the option for re-entry and redirection of guide wires. When a guide wire is ended up subintimal, it is easy to follow this guide wire with a very deliverable recross. So one lumen has the guide wire inside and the other lumen is free to use, for example, to decompress and aspirate the subintimal hematoma. Verify to which direction the exit ports are located. In this case, the proximal exit port is not facing toward the right direction. The second guide wire can go through the blue stylet lumen, and as you can see in this situation, the second wire can re-enter through the middle distal exit port. Because the tip of the device should always follow the guide wire, and the re-entered wires have re-entered through one of the exit ports. The recross device should be trapped out and in again, and treatment of the vessel can continue, while the recross has followed the guide wire through the subintimal space and back into the true lumen again. For more information, visit imds.nl.
So, thank you for taking the time to view this Biotronic technology update. I hope you found the content interesting. Thank you for joining. And please visit the Biotronic virtual booth for further information on our products.
The second day. Very happy to be connected to, I can't say this is my second home country, but a kind of. If there is a country that probably me and my chair panelist really enjoy, and I think, Thierry, you have been many times to South Africa. I have here with me Thierry Lefebvre from Paris and Emmanuel Barbato from Aalst. I pick up my wording again. So if there's really a country that we really appreciate and the people over there is South Africa. And I see already Farrell Hellick over there, and I see somewhere further down, I see Helmut sitting in the room. So I would say without any further delay, and just introducing Evgeny Merkulov, who is in Moscow, also online as a co-chair. We give the word to you, Helmut and Farrell, for the South African session. Morning, Hamilton.
Yes, thanks for the opportunity. So we're broadcasting from Tygerberg Hospital, from the dodgy end of Cape Town, and Farrell Hellick is in Johannesburg. We decided to set up the HUBSPOT here in Tygerberg because it turns out that most of the presentations will be from Cape Town. And we've got 4 cases to present, and hopefully we can show you some interesting things. So with me is Adi Horak. Adi, you must say something.
Must say something.
Hi, Adi. How are you doing? I thought it was you, but I was not sure because you looked a little bit far away. But I definitely spotted you over there. Yeah. Welcome, Adi, to the program.
Thanks, Adi.
Yeah, and then we've got other presenters will introduce as they come up. I think to get the ball rolling, I'm going to show the first case. So the organisers logged this as a coronary case because the title is anterior STEMI, but we'll see in a minute that it was in inverted commas. So the story is of a 40-year-old woman. She had a rheumatic heart disease and received a mitral valve replacement in 1994. I think it was or shortly after pregnancy where she ran into trouble. And she's done very well since then, same valve and no complications. We admitted her 2 years previously with an anterior STEMI and did an angiogram. And as you can see, the distal LAD becomes thin and sort of just petered out. And I wasn't sure whether this was a proximal thrombus that it recanalized, because with the valve, you obviously worry about the possibility of emboli. And the right was unobstructed. And then I did a ventriculogram, and it showed this, which obviously